Good afternoon, ladies and gentlemen. Welcome to the second International Symposium of the Graduation Program in Nursing of UFC, Federal University of Ceará. I am Professor Paulo Arraes from the Federal University of Ceará. I am a pharmacist and part of the project Technologies in Health, Actions and Strategies to Promote Health, coordinated by Professor Dr. Vera Leitão Cardoso. And one of the projects of the Institutional Program for Internationalization of UFC, I was invited to moderate this theme, Access, Technologies in Health and Promotion of Health, that gathers experts from the University of the British Columbia and UFC. As you all know, technology is used in the process of qualification of future healthcare professionals and in promoting healthcare of patients and their families are important tools that allow for us to build collective knowledge that promote changes in attitudes and broaden the access to information and health. Right now, we would like to thank the program that's to support an educational follow-up of the Coordination for Innovation and Academic Development, linked to the Integrated School of Development and Academic Innovation IDEA, which is a supplementary body under the President's Office of the Federal University of Ceará. A support program for educational support for action and academic development, linked to the Integrated School of Development and Academic Innovation. So this is a supplementary body under the President's Office of the Federal University of Ceará. Right now, I would like to invite the speakers of the first panel to be part of this table. Internationalization, Educational Technologies in Health. I'd like to call Professor Dr. Vera Leitão Cardoso, Dr. Wendy Hall,
and
Dr. Suzanne Campbell.
Doutora Vera Leitão Cardoso,
Dr. Vera Leitão Cardoso
enfermeira formada pela
is a nurse with a degree from UFC. She also studied at this university her master's and doctorate degrees in nursing. Has a postdoctorate by the School of Nursing of Victoria, Canada, and has a scholarship of Productivity 1B from CNPq.
Professora titular livre da Universidade Federal
She's a free professor at the University of Ceará. She coordinates the program of nursing since 2017 at the Federal University of Ceará, and she's also the coordinator of the project Technologies in Health, Actions and Strategies to Promote Health, that is part of the institutional program of internationalization funded by CAPS in a partnership with the University of British Columbia, Canada. Dr. Wendy Hall is a nurse with a degree with the University of Manitoba. She had her master's degree with the University of British Columbia and doctorate with the University of Manchester. She's currently a professor of UBC, emeritus professor. Dr. Wendy Hall works in research related to transition to paternity and areas related to child sleep and breastfeeding. Next, Dr. Suzanne Campbell She's an associate professor and provost of international affairs of the nursing school of the University of British Columbia, Canada. As a global educator and an experienced person, she uses technologies and pedagogy, and she directed the development of centers for simulation resources, conducted workshops for professors to be part of simulation in lactation, papers in nursing education, lactation, and innovative education. She worked as VP of International Affairs of the Board of Administrations of the International Association of Nursing for Clinical Learning and Simulated Learning. She also teaches at the Canadian Association of Nursing Schools at the program for simulation, certified simulation of nursing. She works in the Committee of Education and Accreditation in lactation up to date. To open this moment, we'd like to invite you all to watch the institutional video from the Federal University of Ceará.
A Universidade Federal do Ceará é uma das mais procuradas no Brasil por aqueles que desejam ter acesso ao ensino superior de qualidade. Isso se deve ao histórico de mais de 60 anos de conquistas em ensino, pesquisa e extensão. Em 16 de dezembro de 1954, eram apenas 5 faculdades na capital. Hoje são 125 cursos de graduação, beneficiando 30 mil alunos dos campos de Fortaleza, Quixadá, Sobral, Russas, Crateús e através do Instituto UFC Virtual. Na UFC temos o maior número de mestres e doutores do Ceará. São mais de 6 mil estudantes em 80 cursos de mestrado e 51 cursos de doutorado. Nossas pesquisas abrangem aspectos da vida social, econômica e política, com amplo espaço para o estudo das tecnologias. A UFC é reconhecida como a instituição que mais cresce em inovação tecnológica no Brasil. E a inovação tem sido o norte de muitas ações da UFC, com domínio do empreendedorismo e inovação, parque tecnológico, laboratórios de pesquisa especializados, parcerias internacionais e aulas no formato remoto. São alguns dos exemplos de que a UFC se renova e se moderniza a cada dia. Também estamos presentes no cotidiano do povo cearense, com mais de 1.000 projetos de extensão que beneficiam quase 1,5 milhão de pessoas por ano em vários municípios do estado. O nosso compromisso é social. Exemplos disso são a maternidade escola Chateaubriand e o Hospital Universitário Walter Coutinho.
We have a maternity school, Chateaubriand, and the University Hospital Walter Coutinho. Besides free medical procedures, at the hospital we find one of the main reference centers for liver transplant in Brazil.
Os investimentos no esporte e na cultura também fazem da UFC uma das melhores universidades do país.
UFC one of the best universities of the country.
A Rádio Universitária FM, as redes sociais como o perfil UFC Informa no Instagram, o canal UFC TV no YouTube e os canais do Telegram,
UFC TV on YouTube and Telegram channels,
transmitem a essência do
portal
nosso lema,
UFC
o universal
transmits the essence of our motto,
Juntos,
universal for regional, and
entre a
together
UFC
they
e
promote
a
communication
comunidade.
between UFC and the community.
As casas de cultura estrangeira formam o maior projeto de extensão do ensino de línguas na Universidade Brasileira. Elas fazem parte da nossa política de internacionalização e intercâmbios culturais, que fortalecem programas da graduação e da pós-graduação. São essas e muitas outras características que fazem da UFC uma das instituições mais procuradas por estudantes de todo o país. Somos uma universidade inclusiva, moderna e a cada dia mais completa.
And more complete.
Somos espaço para todos. casa,
we have room
trabalho,
for all. We
lazer,
are home,
escola
work,
e crescemos
leisure,
com cada
school,
pessoa
and
que
we
passa
grow
por
with
nossos
each
espaços.
person that passes by our spaces.
Os dois são vivos.
After this wonderful institutional video, we also have the video from the University of British Columbia.
Five, four, three, two, one.
After this wonderful video that invites us to meet Canada in the institution, I'd like to invite Professor Dr. Wendy Hall, and she'll be speaking on the Print Caps UFC as a path for internationalization and the graduation program in nursing of UFC.
Thank you very much for that kind introduction. I'm looking forward to speaking
Pela apresentação.
with our colleagues. I can't see the slideshow. Is it up? Thank you very much. So Dr. Cardoso asked me to speak a little bit about the history of the Print Campus UFC program as a path for internationalization in the UFC graduate program in nursing, and about how our partnership started with UBC. Next slide, please. Next. So whenever you develop something like this, you have to start with all the pieces. And we started with small face-to-face meetings, and then we had invitations for scholarly visits. We started to develop faculty-student connections, and we also developed joint partnerships. So these are just some, next please. Next slide. So these are just some photos of the experiences. The first is with Dr. Cardoso and me and Ana Luisa, the graduate student that I had in a sandwich PhD program in Canada. And the other picture is from one of the presentations I did with students when I had a scholarly visit to UFC. Next, please. Could we have the next slide? Thanks. So the historical background is in 2013.
The background histórico em 2018 e 2013.
There were meetings between myself and Professor Cardoso
entre eu e a professora Cardoso
and Sofia Rodriguez to discuss ongoing work.
Para discutir o trabalho corrente.
And the UFC graduate program.
E o programa de pós-graduação da UFC.
At that time, I was the Associate Director for Graduate Programs in the School of Nursing.
Associada de programas associados.
And I agreed to be the Canadian supervisor for Ana Luisa Leilas. And she was here at UBC from 2014 to 2015. Studying children's sleep. So then I agreed to have a scholarly visit at UFC. I was there for 10 days. Delivered 5 lectures.
Foram 5 palestras.
And served as an examiner for Anna's PhD defense.
Da defesa de tese da Ana, PhD.
I also contributed to a cooperation agreement
acordo de cooperação
between UFC and UBC.
Entre a UFC e a UBC.
So Anna and I had a joint publication.
Fizemos publicações conjuntas.
Following my visit to UFC, Dr. Susan Hinton visited UFC and had a scholarly visit.
Houve uma visita à UFC também.
And we have had some faculty members from UFC come to Canada as well.
Corpo docente vindo para o Canadá também.
And in 2018, I contributed to the development of the
contribuí para o desenvolvimento
print grant.
Do print grant.
So next slide, please.
Próxima slide.
So what are the facilitators for internationalization?
Quais são os facilitadores da internalização?
I think we all have a commitment to global graduate student development.
Nós temos compromisso com o desenvolvimento da pós-graduação global dos alunos,
enthusiasm for supporting student exchanges,
entusiasmo para apoiar esses intercâmbios estudantis,
and interest in cultural understanding.
e também o interesse na compreensão cultural.
Next slide, please.
Próximo slide.
Could we have the next slide? Thanks. Potential barriers to internationalization we've discovered
Barreiras potenciais para internacionalização foram descobertas por nós.
is there hasn't been much opportunity for academic work by the
Há muitas
professors.
oportunidades para o trabalho acadêmico por parte dos professores.
And there are differences with North American approaches to
E há
graduate
diferenças
education.
quanto à abordagem norte-americana, à educação na pós-graduação.
I don't know much about the Portuguese system, but I know about the system in Scotland.
Eu não conheço muito o sistema português brasileiro, mas eu conheço um pouco do escocês.
But really, in Canada, we're a mix of the American approach to graduate education and the British approach to graduate education.
E aqui nós temos no Canadá, nós temos um misto da abordagem americana e também da abordagem do Reino Unido.
So there are challenges when UFC is working with universities in Scotland, in Portugal, and in Canada, when every group has a slightly different approach to how they educate their graduate students.
E é claro que há muitos desafios, né, quando uma universidade como o UFC trabalha no desenvolvimento em conjunto com universidades na Escócia, no Canadá, em Portugal.
There are also language differences, and I am
Também diferenças de idiomas.
very impressed with how well Brazilian students navigate in English.
E eu fico muito impressionada com a facilidade com que os alunos brasileiros conseguem navegar pela língua inglesa.
We haven't been so successful with finding Canadian students who could navigate well in Portuguese.
E nós não temos tanto sucesso assim com canadenses falando português, não.
And there are differences in writing styles.
E há diferenças também no estilo da escrita.
I think it's fair to say that there's a way of communicating in the,
é uma forma de comunicação
in the romantic languages that
línguas românticas
is not quite the same as scientific writing.
Que não é igual à escrita científica.
Having said that, we have very much enjoyed our relationship with UFC.
Tendo dito isso, nós gostamos muito da nossa relação com a UFC.
And we hope that there will be future opportunities for us to work together.
Mais oportunidades para que possamos trabalhar juntos.
Next slide, please.
Próximo slide, por favor.
Obrigado.
Obrigada.
Agradecemos a professora.
Thank you, Professor Wendy. Now we'd like to invite Professor Vera Leitão for her presentation. Good afternoon, everyone. It's a pleasure to be here with you in these 3 days. Could you please load my slides? I'm going to start speaking about the continuity, actually, of what Professor Wendy said and what came before our history until we got to our print program. I am Professor Vera Leighton, current coordinator of the graduation program in nursing of UFC, and I am a 1B researcher 1B at CNPq. Next. I want to start by saying and congratulating our program, actually. You can see in this picture that I wanted to put it on so we could understand the issue of internationalization along with our professors, students, and the goals to be achieved for nursing as science to be truly more treasured, not only in a national context, but also internationally. And this picture shows the moment we started our administration, how much we got in 2017 from the previous coordination directed by Professor Lorena and Professor Elisangela. And we could start our management, our administration with a 6 mark from CAPES, which means that is a program of excellence, of international excellence. So why start by saying that? Because we have to understand that international projection is very important. Internationalization of the program with all its features is very pertinent because knowledge produced and must be socialized not only within UFC or within our country only, but we should fly higher so that our colleagues from other countries, from other continents, can truly understand and know how nursing works at UFC in the graduate program. And that is one of the points that is assessed so that we can keep a program of excellence. So nursing as science is truly a strong way. It's a path that must continue, and it must come out everything that we research and the evidence for the practice of nursing that is more qualified, empowering us in our profession. And as I said, our program has a mark 6 by CAPS, meaning that is a program of excellence. Next, please. So I also would like to say that our program has 3 research lines: nursing, in promoting health education, the nursing care process in health promotion, and health technology, in nursing. In the CNPq Research Group Directory, we have 9 projects of research. We started with our first group in 1993, and our doctorate, our first class, was the class from 1998. Up to now, June 25th, 2021, we have awarded degrees to 529 masters and 310 doctors in nursing that are out there in the world showing their potential from coming from our school. And we have strived a lot to be able to achieve more international goals and doctorate in countries as Canada, United States, Portugal, Spain, and Scotland. I want to mention here the CNPq and CAPES that are 2 fostering and assessment institution of graduation in Brazil. These 2 entities are the ones we want to thank to provide all support, financial support for the working of our program. Next. Here to start speaking about PRINT, the Institutional Program for Internationalization, launched by the Brazilian program, where we, as a federal university, compete with many other universities all over Brazil. We were granted, our UFC was awarded, or we received a grant, a funding involving 16 large research projects, including 20 doctorate programs, 20 countries, 40 universities, 3 companies, and 2 research institutes. This forms the PRINT, where we, from nursing, from PPG, from the Federal University of Ceará, are pleased to take part in. We are going to be talking about it now. So PRINT started with the experiences lived by us with other countries. And you may ask, why Canada? Why UBC is with us? I would like to acknowledge that other projects were part of these great projects in the Federal University of Ceará, but PRINT, specifically of our program, that truly went to tender 41 2017, aims to build and consolidate the strategic plan for internationalization of our program and our university, to promote mobility of students and professors abroad, and also stimulate the creation of international research networks, because we believe that this is going to strengthen our knowledge, our quality, and the science of nursing. So the name of our project and the main print of UFC is in the theme Social Technologies, Health Promotion. The title of our project is Health Technologies, Action and Strategies for Health Promotion. And why did we choose health promotion? First, because health promotion is a transversal topic. It passes through many categories, disciplines of sciences, and we go to the source of other sciences to be able to ground a more qualified nursing care. So our area of concentration is health promotion. And the funding of our project, specifically not for trips or for scholarships of our professors and students that could go to UBC, but for other types of expenses for 262,000 reais and 600 reais, 262,600 reais. It started on August 1st, 2018, and it's going until 2023. The coordination in the print is made by me. Our team is made up of 10 professors, researchers from the Federal University of Ceará, and 3 professors also from the Federal University of Ceará, but from the pharmaceutical sciences, like Professor Paulo Reis, that is here with us today. As foreign colleagues, we have 4 professors from the University of British Columbia in Canada, Professor Wendy Hall, Professor Suzanne Campbell, Professor Susan, and Professor Howard. I'm going to show you a picture of them, okay? So here's our team. I'm not going to mention their names, but here are they. I put in the order of coordination of the project. Professor Wendy here with us today, Professor Susan Painter, Professor Suzanne Campbell, and Professor Ferguson. Below, we have professors, researchers from our program, Professor Thelma, Ana Fatima, Professor Marcos, Professor Gilmara, Professor Lorita, Professor Marli, Professor Christiana, Professor Nirla, Professor Viviani, and the three professors from the pharmaceutical sciences, Professor Ana Paula Gantin, Professor Paula Reis, and Professor Martha. What I wanted to show you is that our program works with main contents for academic mobility. So in 2019, we did our first technical mission in Canada. I have pictures of our meetings with our colleagues from UBC. We took part in events. We presented papers related to the ideas and topics from print involving our project with 3 axes, that is health promotion, another one for child sleep, and other for people with vulnerabilities like people with HIV AIDS, cardiovascular diseases, and another one regarding the use of tools, validation and use of measurement tools for nursing diagnosis. In 2020, we had the entire planning of a new mission in Canada that were there, and me and the 3 professors from pharmaceutical sciences were participating, but with the pandemic of COVID-19, all activities had to be canceled. We know the reasons why. I don't have to repeat them here. And right now, this mission is in standby, but with the possibility to happen as soon as we have all the pandemic conditions, all sanitary conditions, vaccination, immunization, when everything allows us to open the doors to be back for this visit, maybe 2022. Next. Why did I bring this picture here of some of the people that maybe you know, others you don't? Why did I bring this panel of pictures? I wanted to make clear to you as a way of stimulating other people that producing knowledge, building a relationship with another institution, another country, does not happen from one year to the other. My story, Canada, actually came to our program from me because I discovered Canada in 2005 in a congress where me and Professor Lorita and Professor Ana Fatima went. So here is a picture of colleagues I made, not only at the UBC. I have colleagues at the University of Victoria. That's where I took my postdoc. Professor Virginia Hayes. Here are colleagues from the school that are still my colleagues. And I had the opportunity of meeting Professor Marjorie McDonald from UFICI, being part of a bench, our colleague John Watson. And in 2007, when I finished my postdoc, we had here, I got closer to Quantum Polytechnic University, that is the Polytechnic University of Kwantlen. And Professor Balby was one of the persons here in blue. Sophia, our undergraduate student, she was my master's student. Professor Balby received Sophia there, and we increased our relations with Canada. And here we have Susan Harris. She's a physical therapist, a professor, another friend I have. She worked with me, and I work with her tools for development, child development and assessment. Professor Balby then came to UFC, Professor Wendt came, Professor Susan came, and here we were able to send to Canada, based on this internationalization, Professor Anna Kelv. She went there as a postdoc. We also have here in front of UBC the last student that has just returned. She was brave enough to go in 2020, even with the pandemic. Professor Suzanne Campbell, with all her, may I say, kindness and organization and commitment to our program, welcomed Odalea, and she returned in July 2020, even in face of the pandemic, even though all activities were remote. And down here we have Ana Luisa, Professor Wendy mentioned, that welcomed her and advised her work with child sleep, and Camila and Professor Wendy here, that was advisor of Professor Ana Fatma, and they were the people that were able to be there in this short period. Even though we think, yeah, 5, 7 people went there, I think this comes from less than like 25 until now, but we were able to establish a closer relationship with these universities. Just to briefly mention, these are conferences that are more relevant, related to print. And that was the event we went in 2019 from Nursing and Research in Calgary, Canada. We presented 7 papers linked to the print program. In 2020, remotely, we were part of the European conference in Coimbra, Portugal, and also in China, and also the work from our colleagues from the pharmaceutical studies, pharmaceutical sciences, that were supposed to be presence-based, but this event had to be online, and we were able to present our papers. So the project, even though pandemic blocked many of our trips, but the activities that could be developed remotely were, and we did them the way we could. Some publications, 7 papers, 2019, 11, 2020, 2 in 2021, related to this topic, okay, not necessarily published with the foreign teachers, foreign professors. We had 3 published with the UBC professors, and others that were published in journals, international journals, related to the topic, but with print researchers. Next. And just to close here, I have 2 more slides. And my message is that with this program that is leading part of the internationalization all over Brazil, and that's the investment that is being made through CAPES and the government, we have to think that we have many challenges. Pandemic was our largest challenge, but we have the possibility to keep on working together, to keep on working in partnerships within what may come from these new situations we are living in. So what are these challenges? I mentioned some of them here. The first and foremost challenge is the pandemic. We are living a moment we could never ever have imagined, a historical moment. But even within this pandemic moment, we can take good things out of it, because we are having the opportunity to bring forces together to fight this pandemic. And as soon as things get better, we hope to keep on working on the activities that were planned and that cannot be implemented. Another challenge is the mobility of our students and our professors for foreign institutions, especially UBC, through print. Also, this exchange of faculty and from our faculty and the others, it's very complicated to bring foreign professors that can spend a year, 6 months here. We have to overcome these hurdles. Another one is fluency in English. We have invested and stimulated our students, but we know that this does not involve only the professional and the formal, but there are individual matters related to it. Another challenge is to find international impact of our studies developed in our program. We have to work in a robust way in the methodologies of the studies, and we have to have studies that show evidence, important evidence for health, for nursing, and also another challenge we have, be able to have funds and grants, not only for our national institutions, but also partnerships with international institutions, and believe in our potential, trusting us, and the idea that they can fund our research. For the future, we want to have an integration of our research lines, the strengthening of our partnerships. We also aim to have, as a result of these partnerships, academic innovation, publications with our international colleagues, collaborations in research projects in our school here, and also into projects that involve the research lines of our foreign collaborators. And we also have to teach courses, training programs in other languages, not only Portuguese. And here we have new agreements with other institutions, all of that trying to get bigger so we can have the possibility of one day be a program mark 7 from CAPES. That is the highest grade, the highest mark. So closing in my slide, I put this picture because I want to say that together we are going to be more. We need to look at each other, respecting all cultural issues, the individualities, and then we'll be able to put together a model that is good for both sides, and so that we can contribute to those people that are truly in the core of our care. That's the human being. Nursing is all about this. The essence, the core is human care, and that's what we are looking for in our research. Research, things, matters, topics that will increase and qualify nursing care. Thank you. Thank you, Professor Vera. It's a pleasure for us to be in this international program that brings also an interprofessional qualification. Now, Dr. Suzanne Campbell, she will be speaking about educational technologies in the pandemic, resources for open education, simulations, virtual games, and consultancy in telehealth for interprofessional students. Professor Suzanne, you have the floor.
Thank you. Are you able to hear me? And the slides. Thank you very much. So we are almost coming to the end of our last day. And Professor Vera has outlined beautifully how we have been affected by the pandemic. I'm going to share with you some ideas about how we've moved through it and what future possibilities are. So first, I need to acknowledge, next slide, please. Next. I forgot. I am grateful to live and work on the traditional, ancestral, and unceded lands of the Semiahmoo, Musqueam, Tsleil-Waututh, Stolo, and Squamish nations of the Coast Salish peoples. Next slide, please. I have some disclosures that I would like to make you aware of regarding book royalties and boards of directors that I sit on. I do not intend to discuss an unimproved investigative use of a commercial product or device in my presentation. Next slide, please. I wanted to give you an idea of where the University of British Columbia is located. In beautiful British Columbia, the red arrow is pointing there. Our next speaker is one province over, so the red arrow in the blue land of Alberta. And British Columbia is located on the mainland. You will notice there are many islands in the ocean from there. But it is a very large province with over 4 million people, and Vancouver is a very diverse city. The next slide, please. This shows our campus in all 4 seasons. We are in the temperate climate of the Pacific Northwest, but we do get snow on occasion, and summertime is beautiful. Next slide, please. I just wanted to reiterate my thanks, how grateful I am for the honor to be with you during this symposium. And I'm excited to share some of my thoughts and experiences of the past few months and my expertise in innovative education. So my objectives for today, next slide, are to peek at health professional education and how we are supposed to be changing, to describe educational technology use during the pandemic, and to give you a concrete example of the evolution of open education resource modules. I will be applying standards of best practice for simulation and talking about how we can be doing rigorous research to incorporate methods so that we are creating consistent and reliable educational experiences. Next slide, please. We are already 11 years from this landmark document about health professional education for a new century. And I'm not sure how far we have come. But this Lancet Global Independent Commission identified 4 key areas for education for health professionals. First, to be part of interdisciplinary teams. Second, to use evidence-based practice in their learning and practice. Third, to take a quality improvement approach and always be looking to evolve our systems and our practices. And fourth, to integrate informatics. I think the symposium has highlighted in our first 2 days how informatics can be used to better the health of multiple populations. And I'm hoping to share with you another example. Next slide, please. The World Health Organization has created learning domains for collaborative practice. And again, this has been out for 11 years. But I will be focusing today on the teamwork, roles and responsibilities, and communication component. In any learning experience, we hope that our learners will use critical reflection, and practice ethically. Sorry, those were the last 2 bullets. Now the next slide. Obrigada. So what has happened in the last 18 months? We have had to pivot wildly to manage online education and the occurrence of the pandemic. In Canada, we have been using virtual simulations, virtual gaming simulations, telehealth consulting, and some virtual reality and augmented reality. We have only been limited by the creativity of faculty and students who have gone above and beyond to make the learning experiences exciting. So this is an example of the virtual simulation games that we're using, and I'm not sure on the YouTube if the QR code will work, but these are open access games that were developed by Canadian nurse educators, and you will notice on the right that there's an entire hospital. There's an emergency area, pediatrics, gerontology, maternal and child, and a mental health unit. Faculty and students can enter this hospital and have virtual learning experiences. Next slide, please. We know that there are some common issues around integrating any innovative pedagogy for education. There's a lack of research that demonstrates what the impact is, a comparison of traditional methods and new methods. There's controversy around when is the best time to use innovative methods. And in describing and defining how we actually translate the learning to clinical practice. Are we able to measure outcomes in changes of student behavior and patient safety and quality of care? So as disruptive innovation that innovative pedagogy is, like virtual simulations and simulation, there are still many issues around what is best to do. Next slide, please. So we recognize that there are gaps in our educational research, the scholarship of teaching and learning. And the pandemic has set the stage for us to start evaluating this. We were forced to move students into virtual learning environments and to use simulation in place of clinical practice for some areas. And we will be able to measure how this new cohort of nurses manage when they transition to nursing roles. We know that we have not connected our education to the outcomes. And we need to look carefully at the learning experience designs, what settings we use them in and where they work. Another key area is faculty development. What is expected of participants, our learners, in the use of this new educational pedagogy, and what's the role of faculty and facilitators? We also need to make sure that we're applying research rigor to our measurements and process. The literature tells us that the greatest obstacle is time, resources, and support. So, my example today, I will be very upfront that I am biased. After 35 years spent promoting, supporting, and advocating for the rights of parents and infants to feed their infants human milk without interference from artificial milk manufacturers, governments, or society, I see lactation as a foundational strategy for health promotion. Given that, I have created a text with theoretical components around health promotion, but also analyzing the global impact of policies and health professional care for lactation promotion. Next slide, please. So this has evolved into creating a set of open educational resource modules. Initially, we had a team of 4 of us, and 2 were Brazilian postdoctoral faculties from different areas. And we did a scoping review of lactation education for pre-licensure healthcare students. What we found is there were great gaps in education and in the research done about the usefulness of the varieties of curriculum. We knew a potential response to the scoping review was to focus on knowledge translation and creating resources for interprofessional practice. And that led to our open education resource module design. The QR code here is for the open access scoping review. Next slide, please. So the pandemic definitely hit the world by surprise, and a continued need for healthcare professionals meant that university programs were scrambling for innovative methods to teach. Going to describe some of the transition we took at UBC in our health programs. Given the scoping review, we knew that we needed to set goals to provide comprehensive lactation education and practice for all health professional students. We needed to instill confidence in our healthcare professionals to counsel families about infant feeding. And we wanted to create educational approaches that represented body neutrality, that normalized breast and chest feeding, and that were applicable to diverse populations of individuals of color and the LGBTQIA+ groups. The format that we did was a deliberative narrative approach, creating case studies and animated visual approaches. You will notice some of the logos on this page. In the left-hand corner is the Hive, which is our UBC anatomy department run by Dr. Claudia Krebs, who were instrumental in developing the modules. And then the University, Federal University of Guyana and CAPES that were part of the funding for the postdoctoral students on this project. Next slide provides acknowledgements to all of the TLEF team. And you will notice that there are both faculty and students and international students represented here from medicine, midwifery, physiotherapy, and nursing. We also had medical illustrators and instructional designers and support from our stakeholders in the province, BC Lactation Consultant Association. So you all know that no work is done in isolation. The disclaimer is that we did create these modules to provide a foundational knowledge for healthcare providers. They were not meant to be medical advice. Because they are open access and free on the web, we know patients may access them, so we have a disclaimer to let them know that. It's also important to note that the identified practices in the modules fit British Columbia regulations. And so for people using it even in other provinces in Canada or across the world, they need to check their regulations and see how they may alter the modules to benefit them. Next slide, please. So what did we do? We brought together between 20 and 30 professionals. These included instructors, students, I mentioned midwifery, nursing, physiotherapy, anatomy, medicine, and instructional design. And we had several workshops where we actually built and developed these stories and narratives for our cases. We identified learning objectives. We did scaffolding to build the knowledge from each module. And we created 4 online modules. 5 in total. Next slide. It was important to us to integrate diversity and inclusivity. We recognize that much of the language around feeding a baby is gendered, and it does not match how all people identify. So we strove for a gender inclusive way of talking about feeding babies. We also recognize the diversity of families in this day and age. And did our best to meet these goals. So the next slide, please. So what contributed to our success? You will see the variety of university degrees involved there, from undergraduate to graduate students, masters, PhD, postdoctoral researchers, and visiting faculties. As Professor Vera mentioned, the opportunities for international collaboration on these types of projects is wonderful. I think another factor was the multidisciplinary team. We all brought a different lens and worked with parents and families at different points in time. We know that when healthcare providers are supporting families, that there are many factors that contribute to family success and professionals' sense of ability to support. So we integrated through all of the modules the baby-friendly initiative, 10 steps for successful breastfeeding. We used the LOVE method for trauma and violence-informed care. And throughout the modules, identified green flags for situations that were normal and red flags when the healthcare professional would want more information. The magnifying glass allowed closer looks at situations. And we incorporated links to helpful resources, previous modules, and areas to learn more. I think the biggest success was the self-directed learning for students. Next slide, please. This is the QR code to all 5 resources. The first one we created was on the physiology of lactation and has some very simple and foundationally based information, but sufficient for all levels of healthcare providers, pre-licensure, and practitioners. The first module looks at prenatal anticipatory guidance. The second module we wanted to capture soon after birth, and we thought the cesarean section was unique and different, and that would be a good point to capture and demonstrate skin-to-skin care and early breastfeeding was still possible. The third module on effective breastfeeding is within 2 to 3 days, where there are issues of pain and discomfort and the parents need help with positioning and latch. That third module is the one that we base the telehealth simulation I'll mention next. The final module is 2 weeks old infant with questions about growth, occurring in an outpatient clinic. So I encourage you all to take a look at them. In Canada, we are integrating them into our healthcare programs. And we are also looking at them to educate practitioners in baby-friendly initiative hospitals, BFI hospitals. The plan was our students would do these modules, and then they would come together in our simulation lab in interprofessional groups and interact with a live patient and do breastfeeding counseling. Then the pandemic happened. Next slide. We decided to pivot again and create a telehealth simulation lactation counseling session. We invited students from medicine, nursing, midwifery, and PT. They came in groups of 4 on a Zoom platform. And they had a patient, simulated patient, with an infant to counsel. These objectives here were our goals to see, could we use telehealth virtual sim as a teaching method? How would students approach conflicting advice? What would be the role of the standardized patient in this platform? And what were some of the barriers and facilitators to doing it this way? Next slide, please. There are many theories that are useful to guide simulation case development. We tend to focus on Bandura, this theory of self-efficacy and building self-confidence, and Cole. Next slide, please. And this is a theoretical framework that my colleague Karen Daly and I created related to simulation learning. What we hope to do in this telehealth simulation was to provide students the opportunity to think critically, communicate effectively, and intervene therapeutically to provide patient care, and through a debrief, allow them to reflect on how it went. Next slide, please. We followed the INACSL, that's the International Nursing Association of Clinical and Simulation Learning. Simulation standards of best practice. I've listed them here, but I want to focus on number 9, simulation design. And the QR code will take you to the standards, but wait. Next slide. The standards have been translated into Portuguese. So you can access them all with this QR code. And you can see the website and all the other languages that they have been translated into. Next slide, please. So these standards of simulation design are very important to creating consistent, testable ways of teaching. And it's what we did with the telehealth simulation. We had measurable objectives. We created a scenario based on one of the open modules, and we allowed an opportunity for a clinical facilitator to be present with the students while they interviewed the patient, and then provided some debriefing afterwards with the standardized patient and then alone with the students to evaluate their learning and their needs. Next slide, please. So we know that evidence-based practice is important. In developing this scenario, I mentioned some of the guidelines we use, the Baby-Friendly Initiative, 10 Steps to Successful Breastfeeding, and what we know about good latch, communication with parents, and managing lactation difficulties. And teaching with simulation allows us to do this. Next slide, please. I have learned in my presentations to provide warnings when I'm going to be showing pictures of what is considered intimate care and parts. So there are breasts coming on the next slide. Next slide, please. These are high fidelity lactation simulation models. Most people remember the movie Mrs. Doubtfire with Robin Williams when he became a woman. These are the models that they would have used for that. We fill them with distilled water, and we are able to express and massage and treat them like real breasts for students to learn. In the telehealth visit, students did the pre-brief with the first 3 modules. Then they were assigned to rooms to meet the patient. And on Zoom, they met the patient who wore this standardized model and had a pretend infant. Next slide, please. So simply our results, we used anonymous surveys, got student input. We have ongoing evaluation of the open education resources. They have been disseminated globally, and we have over 200 responses. For the telehealth simulation, we were looking at participant burden, fidelity, or how realistic the virtual environment was, and then reviewed with the facilitators, our clinical faculty, and our standardized patient to develop implications for future education, research, and practice. Faculty did gain insight into how best to plan and implement and facilitate the live virtual telehealth simulations with our interdisciplinary students. Some of the advantages were the scheduling was actually easier. It was indeed an authentic telehealth interprofessional experience. It was very easy for faculty to provide support and to debrief with students. And we recognized that equity issues among our students were minimized around the cost of travel and the time involved, but it was evident that there were equity issues related to Wi-Fi and computer access. And those are still areas we need to manage with our virtual education. So to summarize and bring this together, there are key areas for future collaboration and partnership. Next slide. Sorry, next slide. Here are the key areas. To continue to look at the evolving use of simulation, especially with interprofessional students, and what effect it has on patient safety and outcomes. To continue to develop reliable and validated instruments for this type of research. And to be sure to incorporate methodological rigor and consistency in our studies. Next slide, please. These, I thought it would be helpful for you all to see, have been identified as part of the research agenda by Anaxol. And they incorporate many of the design components that I already mentioned, but the faculty development and competency capacity building is keenly important. Next slide, please. So what are the future projects? I've got a QR code to my website, Nursing Simulation Research and Teaching. And I think you will all be interested, as I have many colleagues in Brazil that are working on this, that we've created a global interprofessional therapeutic communication scale. It looks at patient-provider communication, and that is for any healthcare profession. That's the interprofessional part of it. So we've been doing faculty capacity building, testing this scale. We have it translated in Portuguese, French, Korean, and are working on Spanish and Mandarin. We're also creating professionally developed video teaching tools and a virtual gaming simulation. So those are things to look for and things where I would love collaboration. Next slide, please. I've just provided some resources here for those of you who are interested in simulation-based research of any variety and want to encourage you in all of the research you're using to be sure that you're using reliable and valid tools, especially when you do the translation. We've developed a process that we've been using that has worked well. Next slide, please. Obrigada. And the last few slides are just the reference list.
Thank you, Professor Suzanne. As I said in the beginning, technology is an extremely important tool for the development not only in training, but also health promotion as well. Since it allows building collective knowledge, favoring, therefore, a change in attitudes, just like amplifies access to information about health. We are very thankful for the experiences you have shared with us. Thank you so much. So now we'll have 10 minutes to answer to some questions. We do have Edicarla Silva Oliveira's question. She wants to know, Professor Suzanne, what are the difficulties that telemonitoring has found so far?
So the difficulties, telemonitoring, I'm thinking you mean the telehealth consultation. And some of the barriers have been privacy issues in North America. But for both practitioners and patients, they have found increased access and convenience to getting a visit and getting help when they need it, especially for new parents who are seeking lactation support. In part of the simulation that we did, we used photos and pretended that the mother took a picture of the baby latching. And we had photos of a good latch and photos of a bad latch. And it wasn't really the standardized patient, but that is how patients are sharing information with their healthcare practitioners.
Professor Suzanne, here in Brazil, one of the difficulties we have is working with issues related to educational technologies, and these are related to the training that the professors should receive in order to develop those instruments. Over there in Canada, how is this happening? Do you have a team that help you developing these new technologies?
That's a really important question. So, two issues here. The first is developing these modules. And I did have funding from the university to do that. We have teaching, learning, enhancement funds. And I have the technological support. It was mostly students who built the behind the scenes on these modules. And even my lovely website, that was an undergraduate doctor major, pre-med major that created it. The second issue is faculty actually using it. And in Canada, we have the Canadian Certified Simulation Nurse Educator Program. It is 4 modules, 8 weeks each, 4 weeks synchronous, 2 hours a week, 4 weeks asynchronous. And we have about 30 nursing faculty across Canada attending these modules and sitting the national certification exam. We're in year 4, and we have almost 100 certified nurse educators now. So I feel in Canada, we have been very visionary about preparing nursing faculty. That's still barely 1% of the faculty in the country. So there is a long way to go.
Excellent, Professor. Thank you so much. Another question that is quite instigating for us is that here in Brazil, due to social inequalities, many students do not have access to internet connections. And in the beginning of the pandemic, it was quite a problem. But the institution really helped those people out in order for them to gain internet access at the time. Is this still a problem in Canada for the students to become more engaged with the use of these technologies to learn?
I mentioned how big British Columbia is, and that's what I'm most familiar with. But the rural areas in Canada are very much like areas in Brazil, where if students have the monetary resources, there just may not be the technology to their area. In general, many of our students at University of British Columbia live on the mainland, and so access to Wi-Fi is not a problem. I do Monday night virtual simulations with rural physicians in northern British Columbia, and their Wi-Fi is always very touchy. So yes, it is a problem, and that's an equity issue.
Thank you, Professor. A question from Luciana Maramonte Fonseca. She's saying that she would like to hear some more about your experience with this theme of a virtual consultation.
Um, I think it has been a long time in planning. And I want to differentiate a live telehealth virtual simulation, like I shared, and the virtual gaming simulations. If you go to the Ryerson College website that was in my talk with the virtual healthcare, and you enter a part of the hospital, you will have a video game. You are introduced to a patient and you interview them and then have choices. And depending on your choice, a different scenario will unfold. And as you progress through the virtual game, you will get feedback on what was correct, what might have been better. The game will say, choose again, and you know you were wrong. So it's a self-directed teaching tool that helps students think clinically, critically, but it's missing the human interaction. The telehealth virtual simulation allows for that interaction with all of the complexities, the lag in time, the translation issues, if a patient is English is not their first language. But I'm hopeful for the future that we will incorporate it, especially for interprofessional, to do continuing education for our health practitioners, like our general practitioners in the rural north. On Monday nights, we have scenarios with a Google PowerPoint platform. Very simple. But we are still managing critical situations.
Thank you, Professor. Professor Vera, we have this international project. Does it have an important impact in the undergraduate program for the nursing school, for instance? Specifically in the undergraduate course? Well, there is an integration of themes researched with our students from PBIC, they are under scientific initiation scholarships, because the print was really programmed or designed, focusing mostly on the PhD students and professors, not even the master students. These are not included in the quotas for the scholarships they can get for research, but since research in our research group, especially in our department, in our program, works with an integration that is quite strong with master's students and scientific initiations, scholarship grants as well, well, these become integrated in the end. So yes, we can verify the impacts. Actually, they did occur before print was launched, but this would be an encouragement for students in the undergraduate course to try to find ways both for improving their English language skills as well as looking at possibilities while in the undergraduate course to be able to move to a foreign country. In our case, we have Canada and the University of British Columbia, and this is a point of impact, this encouragement, this possibility that in the near future they could be with us in the print group as well. Thank you, Professor Vera. I thank Professor Suzanne, Professor Vera, and also Professor Wendy for being here in this special moment with us, sharing your experiences. Thank you so much for your participation. And now let's proceed with our program with the beginning of the second panel. Thank you very much.
So moving on, we are going to start the second panel. Interprofessional in British Columbia. Dr. Suzanne Campbell stays with us, and Dr. Janet Fuller. I hope I have spoken your name correctly. Welcome. They will be speaking about navigating an interdisciplinary program in UBC, benefits, challenges, and how to be successful. Dr. Suzanne and Dr. Janet, please feel free to start your presentation. Thank you.
So next slide. Is Suzanne, I think Suzanne's doing the slides. Oh, so Suzanne, do you want to read this or I can read it? So this is an acknowledgement that we are, that UBC is on the traditional, ancestral, and unceded lands of the Semiahmoo, Musqueam, Tsleil-Waututh, Stolo, and Squamish nations of the Coast Salish people. Next slide. So I think Suzanne went through her disclosures on the previous set of slides. So could we go to my next slide? So as I say, I have a PhD now, and I had a social work degree, a master's degree in social work before. And I just want to say before I begin that I worked for many years as a consultant, a private consultant with my own company. And I worked with all levels of government in Canada doing evaluation projects, program implementation projects, and policy projects for the provincial governments, territorial governments, and the federal government, primarily the federal and the government of BC. So I had a whole background in doing a variety of projects with many different people on many different subjects. So today I just want to talk to you a little bit about the benefits of an interdisciplinary degree, challenges that I think that I faced and that I think many students might face, and to discuss strategies for successfully completing a PhD in Canada. I just want to say that I think in Europe, interdisciplinary degrees are more common. They're growing more common here, but they haven't been as common in Canada as I think they are in other places. Next slide. So what led to my doctoral studies and the choice of an interdisciplinary degree? Well, I had a career that was well underway, and I had many research interests. And there was a particular area in my working life that I wanted to expand my expertise on. So drug safety and efficacy, a prescription and over-the-counter drugs was a particular interest. I'd done a number of projects for Health Canada, and I'd worked in the nonprofit sector with large national organizations. And I wanted to work in that area. So in a way, doing my PhD was moving into a new field. And many people that are in interdisciplinary degree programs are mid-career or later career, and they want to become more detailed on their degree. I also wanted to work more systematically with I had it. Do you want me to turn the microphone off? I did have it off in the Portuguese. Do you want me to turn it off in the Portuguese streaming? Okay, I thought I had it off there. Well, I have it off in the Portuguese one. So I've got the microphone off. All right, so we okay again on this one? You can still hear me? Yeah, okay. So I also wanted to work with some key experts in a variety of fields. Policy experts, medical experts, experts in doing ethnographic research. And I was concerned about the lack of research on off-label prescribing, which is a type of prescribing where a drug that is approved by a health regulator is approved for a certain use or indication, but then once it's approved in Canada, a prescriber can prescribe it for anything that they feel would benefit a patient. So, for example, and this is a real example, in Canada, a drug that would be prescribed for severe acne, a severe skin problem, has a contraceptive effect, and so the company started to promote it for contraceptive use, even though that was off-label, it was never approved. And that particular example led to the deaths of a number of women in Canada because they had blood clots as a result of this use. And of course, my research question involved breastfeeding and low milk supply. And it was personally like coming home, because I am a very strong supporter of the importance of breastfeeding for the mother and the baby. And I breastfed my 4 children. So I was very pleased to include that in my research. Next slide. So my research question, and you will see that it is very interdisciplinary, was what patient, clinician, policy, and sociocultural factors are associated with the rise in the off-label prescribing of domperidone in British Columbia to treat low milk supply among breastfeeding mothers. I decided to use domperidone as a case example of a drug that is being prescribed off-label to treat low milk supply, even though this drug has cardiac effects and can be quite dangerous. And there is very little research that shows this drug actually helps with low milk supply. But I wanted to look at why clinicians were prescribing this drug and why mothers really seem to want it. I had 4 methods. I had an online survey with family physicians, another online survey with midwives, and that looked at the reasons why they prescribed domperidone, how effective they thought it was, whether they thought it was harmful. I interviewed breastfeeding mothers to find out what their issues were with breastfeeding, why they thought they had low milk supply, and what their experience was with domperidone. And I also did an analysis of Health Canada policy on off-label prescribing. So I had, and just I put the illustration, I had a very interdisciplinary committee. I had number one, a nurse, a registered nurse professor with expertise in breastfeeding lactation, and that was Suzanne. She was my primary supervisor. I had an internist and pharmacologist on drug safety, and he was the head of a very big organization at UBC on drug safety. And number three, I had a physician and health policy expert, and I had a medical anthropologist with a background in pharmaceutical policy. And I have to say that Suzanne, who was my primary supervisor, one of her challenges, I think, was bringing this group of diverse people together who were very tied into their point of view. I mean, they were a good committee, but they saw things quite differently, and I think that's the challenge of an interdisciplinary degree. Next slide, please. So here's the elements of my, here's in pictorial form: breastfeeding mother, domperidone the drug, Health Canada policy, prescribing experiences, and the attitude of clinicians toward domperidone and low milk supply. Next slide, please. So the benefits of an interdisciplinary degree. This is my perspective. I think that in areas of health, having a broad lens in order to understand in a comprehensive way a health problem, or to work on a problem related to health promotion, is the very best lens. And I used a socio-ecological conceptual model that looked at different levels of actors and influences to analyze my problem. And I think having this very comprehensive point of view really is an advantage in the area of health. It was an outstanding learning opportunity for me. To do an interdisciplinary PhD means you really have to know quite a bit about every single level. So every single part, the breastfeeding part, clinician prescribing, policy, sociocultural factors such as medicalization. So it's very, very stimulating for the student. It's also in Canada, interdisciplinary degree is very good for self-directed independence with clear research interests, because a lot of time you're figuring all this out on your own. I was very lucky to have a supportive primary supervisor, but often you're kind of trying to figure out a field on your own. At UBC, interdisciplinary program is very flexible and student driven. I designed one of my own courses and worked with a professor on those. I designed my own comprehensives, which was a really great experience. I designed a whole course for undergraduates. And in many PhD programs, there isn't that degree of flexibility for a PhD student. It lends itself to an article thesis whereby you could publish each chapter as you wrote it. I didn't do that, but it's something that some of the students do. And again, it works very well when you're looking at health-related issues such as public health issues or other models of health. Next slide, please. Okay, over to you, Suzanne. I think this is your slide.
Yes, and this is a wonderful opportunity for Janet to showcase her experience as a faculty member. When you are approached by interdisciplinary students, you almost have to really evaluate the match. And I met Janet at a symposium on campus. She was part of a systematic review for domperidone. I was very interested, and she was incredibly motivated. And as we sat down and discussed our synergies, we recognized that we would work well together. As described in my area of scholarly research related to simulation and my focus on maternal infant health, I'm very interprofessionally focused, and I've spent most of my career working with interprofessionals. So the opportunity of working with an interdisciplinary student is to have an ability to examine research with multiple lenses and to have that collaboration and partnership with interprofessional colleagues. It led to incredibly meaningful research within my own focus area that I didn't see my nursing students having the background to delve into. And part of the joy of working with all graduate students is sharing in that journey and watching their growth and the aha moments and learning alongside them. So to me, benefits greatly outweighed some of the points we experience navigating it.
Okay, thank you. So next slide, please. I'm going to talk a little bit about some of the challenges that I faced. So I think, and again, I'm speaking from the experience of a PhD student in Canada. So I think this applies to many of, all PhDs, finding the right team of advisors. And in an interdisciplinary degree, as I mentioned before, a faculty member might be very wedded or tied into their discipline and not necessarily understand other disciplines. So I had one policy expert and the other a medical doctor. Well, they're both medical doctors, and they have a more linear approach to research, hypothesis testing. And I was using a qualitative approach. And I think that sometimes it was hard. It wasn't too bad, but sometimes I think there is communication issues around people and their particular discipline. As I said before, the choice of the primary supervisor is vital. And some fields, and this is my personal point of view, that some fields in the area of medicine, such as nursing, are more open to an interdisciplinary approach. I think nurses have a huge amount of experience working on interdisciplinary teams. And I've been very, very grateful to have had my home department at the School of Nursing, because I felt that my interest and my approach was understood. I think an interdisciplinary degree is hard work because you need to be credible in a number of disciplines. And so when I wrote my thesis, I had to demonstrate quite in-depth knowledge about everything from the pharmacokinetics of domperidone to all of Health Canada policy to the literature on self-efficacy in breastfeeding to, and then a mother's experiences of breastfeeding. I needed to be able to be confident and experienced in all of those fields. I think interdisciplinary degrees require more self-direction and being more proactive. And it can be isolating because your research is unique. There's no one probably even close to exactly what you're doing. So next slide. So I was just going to end with a few key strategies for a successful doctorate. I think that choosing a primary supervisor who will help get you through your PhD and will handle different people and the needs of the committees, set timelines with you, support you, mentor you all the way through is critical. And I've often thought in Canada, choosing a primary supervisor is like going on a dating site. I mean, you really need to find a way to assess a person's qualifications, interests, supervisory style. Are they too much a micromanager? Do they have time to deal with you? Are they collaborative, respectful? And of course, they need to assess you and find out if they can work with you. So it's a partnership that's extremely important. I think it's really important to build respectful relationships with all the committee members and take charge of meetings and reports and make their job easy for them. Another thing that is a little bit like a long-term relationship is your research topic. It's like being married, but not to a partner, because you're going to be living with it night and day for many years. And you've got to have something that you believe in, that's of interest, that you find relevant and is doable, because you'll get tired of it and it's got to be able to sustain you. The interest in it has to be long lasting. The other thing I was going to say, and I don't know how applicable it would be for all of you, but at UBC, there was a tremendous amount of support I could access on campus. And I deliberately used every bit of support I could. I talked to my professors and the teaching assistants. If I needed extra help or I didn't know something, I'd arrange to talk to them about it, and they were always very willing. I used library staff. I found a library staff person who specialized in health research, and I touched base with her all through my PhD. She was just excellent in helping me with my search methods, my library search methods, because I had a very extensive literature review. I also got statistical help at UBC. There was a program there to help students, and I'm still in touch with the statistician from that program. And there was support for PhD writing, the formatting, the proofing, and there's also social and emotional support on most campuses. And I just used everything I needed, and it was very helpful. Next slide, please. So I think this is my final slide. Before I prepared the slides, I was looking at, information on what qualities does a student need to get through a PhD? And because I don't know what the rates would be in Portugal or other European countries, but 50 to 60% of Canadian students do not complete their PhD. And that means it's a waste of the university's time, your supervisor's time, and your time. So the article I read said it's not, people think you have to be brilliant to do a PhD. And it said, no, actually you don't. What you need is a lot of determination and perseverance. And my motto was take one step at a time. So, when I was doing my protocol, I wasn't thinking about my comprehensives. I knew they were going to come, but I was trying not to panic about that because there were so many steps to take. I think perseverance is very important. Primary supervisor, good support her as well, be respectful of her time, and be proactive in communicating. If there's a problem with committee members, and sometimes that arises, there are established protocols for trying to work out conflicts. And it's really important to deal with problems, especially early in your PhD, because they can become more of a concern. Something that people kept reminding me of, remember, it is your research. Your research is unique, and it is your research. So defend it if you have to. If you believe in it and you put time on it and you feel it's credible, sometimes you have to disagree with a committee member, and that can be hard. But stand up for it. Don't turn down good advice, but remember, it is your research. I think also in Canada, the career options available for PhDs are quite different than they were maybe 20 years ago, 25 years ago, where people could enter into a career stream that would see them having a fairly good chance to get tenure and teach at the university. I think that it's harder now to get those positions, but there are many career options. And I think that it's very important to be creative about that and to nurture your networks, because I think that is where your networks and your interests as you go through your PhD. And finally, it goes without saying that when you embark on a PhD, it's stressful. Many PhD students have families, have work obligations, they're doing other kind of work. And they're on low income many times. So taking exercise, eating good food, getting enough sleep, positive self-talk and relaxation, and maintaining family and friends relationships. Those are the keys for my best pieces of advice for completing a PhD in Canada. So next slide. So I wanted to thank you for those of you who are on their path to a PhD. Good luck, and thank you very much for having me present today.
And Janet, if you don't mind, I could add one last summary. It may come out in the questions, but is that okay?
Yeah. Yeah, I can't hear you that well, so I'm going to turn my speaker up, but
okay.
I won't hear you at all. Okay, go ahead.
I think I'm unmuted. So Janet and I, in preparing this presentation, we're talking about this perception of interprofessional doctorates. And I think that what I realized is there was kind of a stigma because of the unknown of it. And it was easy to think of them as being maybe less rigorous, less scientific, debatable. And I think, historically in the School of Nursing that has been very focused on rigorous science, that has been an issue. But what I've realized is in having this experience is that really, as Janet said, these students to master an interprofessional doctorate have to be a jack of many trades. They have to have expertise in many areas. And part of that interviewing, getting to know each other, is a level of maturity, self-directed learning, capability with, in this instance, a clinical background, pharmaceutical policy background, and then the social work and exposure to lactating families was huge in expertise and knowledge to do this. And the things that really made a difference for me are everything that she outlined in being respectful of my time, setting agendas before our meetings, developing very specific timelines that she kept to. I mean, those are all the things from a faculty perspective that make the supervisor and supervisee relationship so ideal. So it's been a wonderful experience for me. And I think we've outlined some of the positive outcomes of it. And I'd be curious for any questions from the audience. I think we still have about 100 people online.
Thank you, professors. And I'm sorry, I forgot to read Professor Janet's curriculum. She's a social worker. For many years, she was the founder and director of a consultancy company in Victoria, British Columbia, Canada, where she managed over 100 research and planning of public policies projects for the federal and provincial territorial governments. She was president of the Canadian Network of Women's Health and was a member for 2 mandates of the Health Canada Experts Panel on Surveillance on Pharmacological Products. She coordinates a site on safety of medications, and she's for Health Canada. She's an assessor for the House of Representatives about off-label prescriptions, and she is a member of Independent Voices for Safety of Drugs, a national organization of public policies related to drugs, and she works on the Canadian Prescribing Network, a national initiative that deals with the excessive prescription between more elderly Canadian. Professor Janet, I was so thrilled about your experience, about your interprofessional doctorate. I want to greet you. And now let's have questions. We also have a video, right, Professor Suzanne? We have a video from Canada. So maybe we can play the video first and then open for questions, okay?
Thank you.
Sure, whatever works easiest.
Wonderful video. Let's open up for questions. Hayani Lopez is asking, is there any research being developed on breastfeeding during the pandemic of COVID-19 in Canada?
Suzanne, you have an answer to that question. I'm sure there is. I know one of the things that came up in my research from the breastfeeding mothers was the lack of a peer group support at the public health units. Because after a woman leaves the hospital, most births do take place in the hospital in Canada, although some take place at home. People are reliant on public health nurses and midwives visiting them. And women used to go to public health units and meet other mothers and just share stories. And also there is a North American group called La Leche League, which provides peer group support and meetings of mothers. And all of those were canceled during COVID. So women were really not able to meet other mothers personally, and I think that was probably a very huge loss, but I don't know what research has been done on it. Suzanne, did you have any comment on that?
I do. It is part of why we developed the telehealth virtual simulation counseling example. The patient in there had been sent home after 24 hours with no support, no family, and was having issues. And so this allowed students to practice live consulting. I know across Canada, our lactation consultants, at the start of the pandemic, I was involved with the COVID task force, creating learning opportunities to get our lactation consultants graduated from their programs. And then I moved into working with our BC Lactation Consultant Association to create both prenatal classes for parents and then postpartum support for lactation. So yes, that's how we've moved, but we've seen that the resources are not there.
I think in Canada there is a concern that after COVID there may be less support from the government for breastfeeding mothers to meet together to get that kind of woman-to-woman support, which is really what women have done for hundreds of years. I mean, they've met and they've talked with each other, and that to me is very irreplaceable. And I think the feeling is, and that this would apply to medicine too, that after COVID, a lot of medical treatment and support will be telehealth, which has advantages. And it's useful in many ways, and including the example that Suzanne gave, but it doesn't, we still need the personal contact. And the mothers that I researched in my survey, we're doing a lot of searching about low milk supply online. And they were getting advice that was not accurate in a lot of ways. So there is a concern about that. They were being told to take domperidone at a very high dose level. Now, domperidone isn't approved in Europe for low milk supply. And in fact, the European Medicines Agency has issued warnings on domperidone because it affects the heart. But in Canada, we don't have that same level of concern about it.
Next question is from Alexandra Ferrer. In the clinical practice in Canada, do you see this interprofessionality, or it's more into the educational field?
That's hard to say. I'm not sure I can answer that. I think to some degree, yes.
I can answer. So I taught in the US for many years as well, and moving to Canada, I was hopeful. We teach interprofessionally, we bring students together. I am just beginning to see, we're calling them medical homes, but they are areas where we have multiple disciplines.
Right. Yeah.
Doctors, nurses, nurse practitioners, pharmacists, dietitians, social workers, managing patients together.
Yeah.
I think they are rare, but that is a goal we're working toward.
I mean, it's always been my belief that nursing had a very interdisciplinary focus right from the beginning, because they often worked on medical teams, but provided a huge amount of the care. So do you feel that that's the case? Is that a fair comment about nursing per se?
I see nursing as sort of the umbrella.
Yeah.
Because we know so much about the different areas, but and the nurse practitioner role allows a little bit more of the delegating and management, but in reality, we all need each other.
Yeah, we do.
And we need the different lenses, and we will serve patients best when we work together.
Yeah. Well, I was also going to say that the approach I used for my thesis, which was to use a socio-ecological model that had representation from clinicians, patients, institutions, and policy, and socio-cultural factors, was the kind of model that was used, for example, in HIV/AIDS at the beginning. When people wanted to look at what is the best approach around sexual practices. You can't just look at it from a very narrow perspective. You need to bring in the clients, you need to bring in the practitioners, you need to bring in a whole range of people to get the truth of the matter. So it has a history. It definitely has a history, particularly in health and health promotion, interdisciplinary research.
Another question from Hayani Lopez. How to overcome the problems inherent to our education when we are so little valued, especially for the public administration, especially here in Brazil? How do we overcome the inherent problems? I mean, do you have those problems with valuing the profession in Canada?
Are you saying how do you help people become more respectful of other fields and able to work with other fields?
She means that the government does not treasure the profession. So
yeah, I think that's
do you have
true.
That?
I think that's true. One of my supervisors, who is a medical doctor, told me that a lot of medical doctors who were interested in drug safety issues like I am wouldn't understand my approach, and they wouldn't necessarily believe in it. They believe in hypothesis, yes, no, no hypothesis. I mean, it's very linear, whereas my research was more expansive. I think it is a problem with disciplines not respecting and understanding each other, and not willing to work, or not feeling comfortable about working. And so in that way, I think my thesis was probably a good experience for some of the people that were on my committee, who maybe hadn't done that kind of approach. I was lucky in that I had, committee members that were very experienced. So, I'm not saying they were having problems respecting the field, but I think there are real divisions in the way different research areas or domains see the world. And in a sense, the interdisciplinary degree breaks that down, or says to the group, the committees, you have to see it from all these angles, because that's what we're doing here. It's not, So I think it's challenging, and I think the student has to take some of that on, by being very credible in all the fields.
I also think that you are referring to the placement of nursing and the lack of respect for nursing in Brazil and in many parts of the world, where nurses are seen as handmaidens to physicians. In North America, we have advanced nursing practice and science, and our advanced practice nurses are leading the health system changes. And still, we fight that hierarchy with medicine.
Yeah. And, I think the other interesting group that we haven't mentioned is the public health sector. Because I don't know what it's been like well, I do know some of what's been going on in Brazil, but there is a lack of respect among many domains for the public health sector. The traditional medical domain of physicians and practicing and practitioners and clinicians don't hold the public health sector in very high regard. In Canada, it tends to be underfunded, not prioritized, and there has been a real conflict with government undermining the public health sector, and that's happened in Canada as well. And how do you get respect for the public health sector, which to me is absolutely vital for the health of citizens? I mean, when you think of public health measures, they contribute so much to our general health. I'm not just talking about vaccines, I'm talking about the whole range of public health. So I think it is a problem of that mutual cooperation and respect.
Thank you, Dr. Janet, Dr. Suzanne. Very interesting approaches. Your experience was amazing. We want to thank you, and we would like to move on with our program. And we want to thank you for this special moment. Thank you.
Thank you very much. I really enjoyed meeting you all. Thank you very much.
Thank you.
Muito obrigada.
Now we're going to hear to the presentation of works that the students of nursing school have done in UFC, and we have two guests. Tamiris Rebecca Forte-Viana, PhD student, and Diana Maia Saboia. We invite the PhD students to join our group here and our presentation. Tamiris has her undergraduate degree and master's degree by the Federal University of Ceará. She's a specialist in pediatric and neonatal nursing in Fonetro. She's a PhD student in health promotion by the Federal University of Ceará. She is also an assistant nurse working in urgency and emergency sections. She follows patients with high-risk classification and also mental patients. She's working with nursing things, pediatric, neonatal, and children care nowadays. So our guest, Diana Maia Saboia, is also a PhD student in graduation program in nursing in UFC. She has a master's in nursing by UFC. She's an expert in residency in women's health and children's health as well, and health management at the International Integration School of Lusophonic African Brazilian students. She has a degree here in UFC, and she's a member of the multidisciplinary group on women health issues and also the pelvic floor diseases. She's has emphasis on dysfunctions and disorder of the pelvic floor and vaginal issues involved with birth. So I'm going to invite now Damiris and Diana for your presentations. Thank you. Welcome. Good afternoon, Professor. Good afternoon, everyone. I am about to share now my work here. Can you see it well?
Ok,
Okay.
ok.
Okay. Okay, so good afternoon, team. My name is Tamires. I'm a PhD student at the Federal University of Ceará, and I'm here bringing you today a little bit of the work I have developed during my PhD course.
Tamires, por gentileza,
Tamires,
tem um microfone a mais
please,
aberto e
I
está
think you have an
dando.
extra microphone on. Okay. Do you see it well?
Não, está bem distante a
No, it's
apresentação.
quite far away, your presentation in the Portuguese channel. And what about now?
Agora melhorou.
Now it's better.
Precisa ampliar a
But I
tela.
think you need to make it bigger.
Visualizar no StreamYard em
Visualize
inglês.
on StreamYard in English.
Se você for
Tamires,
preferir, nós podemos
if you
também passar
prefer,
os slides.
we can also pass the slides for you. All right, Professor.
Pronto, eu acho que agora já
Okay,
está.
thank you. Now it's going to be fine. Okay, so let's do it. These data are preliminary, right? I'm here to share these data with you because they are part of my study that is being developed in the PhD course, and these are part of a pilot test and also part of the stage 3 of print project that was developed together with Professor Vera and other international professors. Next one, please. Initially, I'm going to bring you a sentence Fernando Pessoa said, where he mentioned that whatever sleeps is a child again. And why this is making this comparison that whatever sleeps is a child again, and whatever is a child will sleep again in this process of growth and development. Let's go. First, why study sleep? Sleep is characterized mainly as the basis of basic human needs. It is mainly related to recovery and the establishment of corporal systems, as well as the good performance from the body. Although with the technology advancements, economic and social influences, and exposure to light, which humans are more exposed to, this human need is often neglected. And what are the main repercussions of sleep deprivation in adults? They are interconnected mainly with changes in the activities and connections in the brain, which might influence in the attention, performance, emotional responses, memory skills, and others. The sleep behavior has followed humans or individuals ever since the fetal stages, neonatal stages. We were able to identify, for instance, REM and non-REM episodes, even though there are adaptations in the neonatal stage, in order to start their consolidation in those children. The sleep behavior in children, on its side, encompasses many nutritional components and stimulation that could be considered essential to assess the positive development in the first childhood. These adaptive components suffer influence mainly from language, literacy, emotional regulation, and behavior regulation, as well as attachment and family development relations. What can cause effects on children's sleeping patterns? Some of the studies we are able to identify nowadays, we can notice that the sleeping habits of children and their parents will cause an effect that is much bigger than neonatal aspects like weight, gestational period, and so on. So, what is the role a nurse could play facing this identification of sleep problems, identifying those altered behaviors, which could have repercussions for the long term in the children's life? In a nursing consultation, a nurse could be identifying through parents' reports and interaction the parents have with their sleeping processes and integrating a sleeping routine for their child. They could tell the relevant alterations in building this hygiene for children's sleep. This is where we see a need and the reason why I decided to talk about the construct of auto-efficacy or self-efficacy, which is mainly related to that ability of a parent or an individual to perceive himself or the ability he has or that he possesses over his own actions and reactions. And also this ability that could interfere in the individual's choices. So auto-efficacy or self-efficacy is identified by Adamson and Macedo in 2015 as a construct which works as a tool that can analyze the relations between mothers and babies, and these could be effective when we work in sleeping behaviors in children. So we have this proposal for using the construct of self-efficacy in order to promote and identify the sleeping behavior for children through their parents and work with this health promotion, especially in the first years of life. Trying to build the instruments that will approach mainly this ability parents have to identify these altered behaviors in children. Self-efficacy from parents is able to select as a primary source of information to identify this pattern of sleeping in children because the parents are the primary sources of information in the first years of life. This repercussion of problems when sleeping or waking, these are all reflecting the parents' sleeping habits and the ability to identify the altered behaviors from parents can be identified during the nursing visits in the first years of life. Besides, self-efficacy is suggested to be able to promote autonomy from the identification of altered behavior or not, in a sense to align this treatment as the parents are able to identify this altered behavior from the moment he feels capable of identifying these behaviors that are not accordingly. He is able to align those cares together with the nurse. These all promote a good, healthy behavior in sleep, which is healthy. Other relevant issues, which are always being approached, and we noticed during the development of our work, are mainly related to the social aspects of children and the environment that children lives in, like screen time, attachment, cultural, parental influences, as well as eating habits and caring for children, which are very relevant during the construction of this sleeping behavior in the first years of life. So the main goal, my main goal, together with my supervisor, Professor Vera, and my supervisor, Professor Monica, involves building an evaluation as an instrument for allowing the parents to identify all the sleeping behaviors in their children until they're 2 years old, and this will validate the instrument that's built and also validate the measurement abilities of the very instrument. The methodological elected process in this moment we have psychometrics. It was a psychometric method we used, Pasquale's, and the construction of this self-efficacy instrument assessment has to do with the Bandura self-efficacy theory to identify sentences that are capable of identifying the parents' abilities to identify altered behaviors or not in their child in the first years of life. These data initially they were collected from the pilot tests in the pediatrics outpatient clinic at the UFC hospital and the coordinators of family development. This is a little of the methodological process. The stage we are in that we're using for the creation and development of this pilot test is still the theoretical part proposed by Pasquale, where you're going to build an instrument that's going to operationalize items and apply that pilot instrument and previously if assessed by a jury that is going to approve that as a pilot project. As I said before, the theoretical core involves building the theory on the construct, which is evidently the theory related to the construct of self-efficacy. A very extensive review of literature was made both online and print literature, and these groups were grouped, assessed, categorized according to behavioral, physiological aspects, and all of these items, all of those indications we were able to identify in literature were characterized. Actually, they were classified, and then we built a pilot test to apply in the target population. This pilot test on its side is going to initially assess those items, which are the content that we're going to analyze, and the understanding the parents might have on the pilot test and its use. The project has been approved, it's ongoing at the moment. So the first results we were able to find looking at this evaluation of how the instrument was built originated the scale of assessment of self-efficacy, including 28 items that are still going to be later reorganized, reevaluated, and the results of this pilot test, they are going to be of extreme importance for building and improving when it comes to content or categorization of items as well as instruments and others. The pilot test is now finished. During the application of this pilot test, what were we able to identify or perceive from the application of the test and the evaluation of the test content? It's just that even though the main goal of our test was to evaluate self-efficacy, considering the pilot test would be able to assess the content of the instrument. So many parents were feeling incapable or uh, incapable of exercising such behaviors or actions that were proposed in the items. For instance, I'm bringing here some items that were built and some actions that were built according to the construct and according to the indications we found in literature on what would be a proper sleeping behavior. For instance, I'm capable of putting my son while awake or sleeping at the place where he usually sleeps. Many of the parents who, at the first moment looking at this item, knew it was about content. They did not feel capable, for instance, of putting their children awake or sleeping in his sleeping place. They thought this behavior of being awake or sleeping in the place where he sleeps was still incompatible with the routines they were exercising. And there are other cultural aspects that were identified related to this item. Not only the evaluation of the content, for instance, a cultural aspect that was very much identified regarding the evaluation of this item is that many of the parents are using, for instance, the process of making the child fall asleep or the sleeping and going to bed routine involves rocking in a hammock, which is a cultural thing. It's related to the Brazilian climate, you know, and the northeastern reality that we live here. Other items like I'm capable of putting my son to sleep without he starts sleeping in my bed or hammock, or I'm capable of understanding that I can share the same bedroom with my son or daughter, and fourth, I'm capable of identifying the cause of my son's being awake, and five, I'm capable to make my son or daughter go back to sleep after less than half an hour after they wake up. These are all being evaluated at the moment according to their content. The first results were that our items were based mainly in findings related to sleeping arrangements of parents with their children and using screens and electronic devices, especially in the first years of life. And when it comes to objects, those that are used by parents to induce sleeping, what would be these objects that put children to sleep? What are those that are using the sleeping routine and the sleeping process or waking processes in the middle of the night? Well, from the first results, as I mentioned before, what we can perceive is that the evaluation of the pilot instrument, even though it was not the focus really, allowed us to notice that self-efficacy of parents, it's still a little characterized as a low self-efficacy in identifying the sleeping behavior and feeling capable of putting the child to sleep and building a sleeping routine for their child to be incipient, really. This evaluation of the instrument has shown other results that are also going to be taken into account in building the next stages of our study, as well as the practices, the relevance of practices undertaken in that environment, that influence of the external media and its influence on the children's sleeping habits, which is well identified in literature in the first few years of life. So I would like to thank you all for your attention, and I would like to also finish with a sentence from Albert Einstein when he said that the secret of creativity is in sleeping well and opening your mind for the infinite possibilities. What is a man without dreams? Thank you very much and have a nice afternoon. Thank you so much, Tamiris. It was These were beautiful words from Albert Einstein indeed. We now invite Diana Maya Saboya to deliver her presentation. Welcome, Diana. Good afternoon, ladies and gentlemen. I would like to start by thanking you for your opportunity to share a little bit of our work. As the professor already introduced me, I am part of the interdisciplinary group of research and investigation on the pelvic floor. So, this work that I'm presenting here today is indeed the portrait of a larger work that we are currently developing. It's been around 4 years. This work that I'm about to present to you is my PhD thesis. It's under the supervision of Professor Camila Vasconcelos. We are developing initially an educational technology under the funding from CNPq, and now we're in the randomized clinical trial in order to test the efficacy of this application that I'm going to explain to you about. The title of our work is Effects of Continence App on Women's Knowledge, Attitude and Practice about Urinary Incontinence, a randomized controlled experimental study. Can you pass the slide, please? Urinary incontinence is characterized by the International Society of Incontinence as being any involuntary loss of urine. Besides being a public health issue that is quite significant, urinary incontinence generates social, economic, and hygiene issues in those who are affected due to the fact that as you lose urine involuntarily in environments such as work, school, gym, church, and other leisure environments, make people who are affected by this condition avoid social contact due to the embarrassment they have as they lose urine. There are economic expenditure as well by using diapers, pads, often cleaning your clothes, as well as those expenditures that are financial with hygiene, like too much soap and changing clothes. We do know that the prevalence of urinary incontinence is higher in the female population due to several aspects, like aging, but more than that, the anatomy of a woman. Between this group of women, the group of women we were looking at during the pregnancy and puerperal period and women in the postmenopause, these are the ones that are most affected by incontinence. During the pregnancy and puerperal cycle, this is due to hormonal alterations that are typical of pregnancy, causing a loosening on the ligaments and the pelvic muscles that prepare the woman for labor. Besides, we have the size of the uterus that grows with the fetus and the weight of the baby and amniotic fluid and all of the structures that are going to be forcing the pelvic floor even more. And in the postmenopause, the main alterations are due to hypoestrogenism. Can you pass the slide, please? Prevention of urinary incontinence is mainly due to training the muscles of the pelvic floor. Since this intervention is level A for evidence in terms of prevention of urinary incontinence, and this is due to the fact that when the muscles are trained, this causes an increased strength and tonus of the pelvic floor muscles, which will allow better support for the bladder and urethra, and are also going to be perfecting those sphincters and improving their strength, and this will cause more continence. But it is known that knowledge, attitude, and practice women can have in terms of training their pelvic floor is very deficient. Literature, not only in Brazil but worldwide, brings the information that people still have limited knowledge regarding preventive measures they can have in order to prevent urinary incontinence. And many women don't refer that problem or they don't search for professional medical care either for prevention or treatment of urinary incontinence due to embarrassment or not understanding that they do need professional help. Many women, especially in the pregnancy puerperal cycle, understand incontinence as something typical of that stage. They don't recognize that as a disease, which actually prevents those women from reaching out for help, both in terms of prevention as well as treatment of urinary incontinence. Facing this scenario where this lack of knowledge from women regarding preventive measurements for urinary incontinence, our research group has developed around 2017 or 18 an app called Continence App. It is an educational application which was constructed and validated by a jury of specialists in healthcare, communication, as well as IT, and it's also registered in a bank of apps in Brazil. This app was built under a model based on health beliefs, which approaches in a playful and simple language the concept, the risk factors, and forms of prevention of urinary incontinence, focusing mainly on training the muscles of the pelvic floor, the AMP here. And literature states that this is the best possible result in terms of prevention. Therefore, the goal of our work is to look at the effects of the use of Continence app in the knowledge, attitude, and practice of women after the delivery when it comes to urinary incontinence. As I said, this is part of a larger study which has a design as a randomized clinical trial that is parallel, non-blind, and double-armed. And our sample is composed of puerperal women from vaginal delivery on time, and they are in the puerperal period staying in the same infirmary. They all know how to read and write, and their smartphones are compatible with the app. So what I bring here for you is a preliminary analysis of our data with 85.3% of the sample, because we're still in this stage of data collection. So you can see that from our final sample from 136 women, this analysis was done with 116. After the application of the consent of being well informed, we proceeded with collecting data from these women in the infirmary in the postpartum section of our hospital. They were later randomized for two groups. The intervention group is using Continence app. So after the term of consent and data collection, a member of the team of research downloads the app on these women's phones, in, those in the intervention groups, and explains how to use the application. And the women in the intervention group, they are also under the routine cares in the maternity hospital where the study is taking place. The women in the control group, after the term of consent is signed and the data is collected, they are only going to be undergoing the regular care that is routine in the institution. Next, please. Regarding data collection, it is done in two moments. As I said, data collection from baseline is done in person. We collect identification data. We use the assessment scale for knowledge, attitude, and pregnant practices regarding urinary incontinence. Even though this scale was built and validated for the use in pregnant women, it's still the closest instrument from our reality when it comes to puerperal women. So we decided that we were going to use this as a baseline. After we have the baseline collected, data is collected 3 months later by phone, and we're going to measure the outcomes. If the scale of knowledge, attitude, and practice is going to be applied again, and this scale was built and validated by our group with 23 items and divided in three subscales. One is knowledge, one is attitude, the other one is practice. The kappa coefficient was 0.84. Each question in the three subscales has points varying from 0 and 60 to 60, with 6 points in each subscales. So the more points a woman achieves, better is her knowledge, attitude, and practice. So when it comes to our results, looking at this partial analysis, what we have so far is 116 women. And this first table shows the identification data for those women divided in the control and intervention group. So we have in the majority, the vast majority of our sample is composed of young women. The average age is between 25 and 26. And in the statistics test, these groups are similar when compared to the baseline in these characteristics. The median years of education is 10 years. Most of these women have unpaid jobs, and the amount of pregnancies, deliveries, and abortions is also similar in both groups. In the statistics, the groups have shown to be identical. So in the next slide, I'm bringing you knowledge, attitude, and practice of women in the control group, both in baseline as well as in outcome. So you can see that in the baseline, we have this knowledge of around 53.5 It was a medium score, and this knowledge was lowered 3 months later. It tends to lower 3 months later, but this data is not statistically significant yet. When it comes to attitude of women in the control group, results point out and show that the attitude of women diminishes after 3 months after delivery. And this data was significant, which means that women in the control group, they have a loss in their attitude when it comes to urinary incontinence after delivery. So the practice of those women remains practically the same without any alterations in the statistic tests. This next slide, I'm bringing the data from the intervention group, the one that was using Continence app, our educational app. When it comes to knowledge, we can tell there is this trend of increased knowledge after the use of Continence app, but this data was not confirmed yet by the statistic test. We're expecting in our thesis for this knowledge to be really different as we finish collecting data. When it comes to attitude, we also notice a reduction in those women's attitude even by using the app, but this data was not significant yet either. When it comes to practice, you can tell the difference here. The median score on baseline was 13.2 and it rose from 27.4 after the use of the app. And we have the statistic test that confirms this increase. In order to finish, we have this preliminary analysis where the use of Continence app is indeed improving women's practice as they were using the app. And the use of the app also points and shows an improvement in their knowledge regarding urinary incontinence, but the data is not significant yet. Here we have the references we use for our presentation. Thank you very much. Thank you, Diana.
Let's move on to the Q&A session. Two important research. First from Ellen Ferreira. She's asking Tamiris, according to the literature, what is considered a adequate sleep behavior for children? And what actions that the nurse must develop with parents to promote a healthy sleep behavior in children?
Pronto, Ellen. O comportamento do sono da criança,
The sleep behavior in children is considered adequate depending on the age of the child. With the development of the child that is closely connected with the brain development and the sleep, that depends on the landmarks of development. Of course, the sleep behavior of a neonatal baby will differ from a child in his first year, second year of life. So an adequate behavior will depend on the age of the child. Obviously, there are behaviors, sleep behaviors, they're more influenced by sleeping habits that were implemented by the parents or developed by the child in the first years of life that can be considered altered or not, regardless of age. Probably because these behaviors, these habits that were implemented may be associated with other altered behaviors along the years. So your question is that it depends on the child or the age of the child. The actions that the nurse must develop with parents to develop a good sleep behavior? Well, mainly the routine implemented by the parents. The main actions that we can work with the parents in the first year of life refer mainly to the implementation of an adequate sleep routine for the child. What are these actions? Well, these actions will develop a sleep routine that is successful, that is favorable to the stimulation development of the sleep of that child. Like, for instance, the child usually sleeps at the same time. They have to avoid using screens before sleeping. The period that time awakes during the night, what actions the parents have to take, what measures, how to behave during the night, and especially also regarding the awakening of the child. What we identified in literature is that these behaviors of the children are related to the parents' behaviors, behaviors that they usually have when they sleep. The child learns those habits, associates those habits, and incorporate those habits from the parents into their routine. And this is going to interfere in the consolidation of the child in terms of favoring the child to have a consolidated sleep at night, waking less times, or micro awakening. I don't know if I was able to answer your question well, but if I wasn't clear, please, you can redirect. Great. Another question from Alessandra Ferrer. Speak a little about the sleep repercussion in the life quality, the quality of life of parents, especially the mothers. Well, Ale, we used to speak a lot about it, right, Alessandra, during your pregnancy and the first years of Valentina. Alessandra, the repercussion of the sleep as to the quality of the of life of parents, of sleep of the parents, is a mutual behavior. The parents have sleeping habits and awakening habits, and they teach these habits to their children. And this repercussion is mutual. The child behavior influences the parent's behavior, and the parent's sleeping behavior influences the children's sleep behavior. This repercussion, the quality of life, may be especially negative if it's not worked on correctly in the first years of life. What we normally see is that in the first years of life, parents adopt certain habits, certain behaviors of implementation or facilitation of the sleep. And with the years, they want to remove these. They want to abolish these habits, take them out of the child's routine. But the child has grown. They learned that habit is what facilitates their sleeping behavior. So the main hurdle we find in this pilot test is exactly this. Encourage the adoption of habits in the first months, the first years of life, and then these have to be abolished. This repercussion, this sleep behavior will make the child feel different in the environment, and it may cause more awakening times between the sleep and wake up moment, and it will cause the quality of sleep of the children to reflect on the parents' quality of sleep. because it also interferes with their full uh, sleeping routine during the night that is satisfactory in terms of recovering the parents, the adults, the parents of those children from those daily activities. So the repercussion is negative oftentimes because some parents expect the child to have their own sleep behavior, that they build their own sleep behavior. But oftentimes they don't understand that they have to facilitate that introduction, that routine, those habits, those daily habits. Thank you, Tamiris. One question to Diana from Camila Teixeira Moreira. What are the greatest challenges when collecting data to test a technology that requires a long follow-up, 3 months? We have found many challenges developing a clinical trial that is randomized. It's a complex method. So developing studies with this method is quite challenging. As a group, we have helped each other, but there are limitations. Initially, our audience, we decided to develop this work and testing this technology with postnatal women. The postnatal moment is unique for the women, for a family. It's a moment of change. The families find a lot of challenges with all the new roles they have to develop, that new member of the family. So there's breastfeeding. And within maternity, when we get data in immediate postnatal, we see the baby crying, the baby's having difficulties being breastfed, the mother with problems on the breast. So all these issues, cramps, postnatal cramps, all these issues get in the way of the adherence of this woman in terms of participating in the research. As for the follow-up, we face greater challenges. As I showed you, we chose a phone follow-up 3 months after the baseline. So we have the challenge of getting in contact with these women by phone. It's very usual here in the Northeast in Ceará. I don't know if it's a Brazilian reality, maybe in the world, but here in Fortaleza, in Ceará, it's very common that the women, the people, especially those with a lower income, they change numbers. They change phone numbers very quickly. So we have a great loss in the contact with these women. And this is a criteria for discontinuation of the work. We get in contact with these women in the postnatal nursery. And when we try to get in contact with them, it's either disconnected or the phone doesn't belong to them anymore. So these are the main challenges for data collection. This clinical outcome in 3 months and a method of getting contact with them by phone. Camila also would like to know if you have any preliminary data on the adherence to training to the pelvic floor that the app proposes. Yes, we do have some data. What we see, I don't know by heart, but what we see is that a great part of women start using the app, some in the hospital, others when they get home, and they are not able to complete the steps. The app proposes a training of a pelvic floor that lasts 12 weeks. Some can do it, go through to the end, but most women say they are not able to finish due to the multiple tasks they have to develop postpartum. So they say they care with the baby, the limited time. These are the main limiting factors for the use of technology. Another important topic is related to the use of the phone. They say that their phone broke, that they needed to change the device. That's why they did not download the app again. So generally speaking, women use the app. Those that use it, not all of them can finish the steps because of the demands postpartum. And those that don't use it, most of the time say they had problems with their phones or the demands with the babies. Thank you, Diana. Thank you, Tamiris. We wish you both success in your doctorate degrees, and we are waiting for the results of your wonderful research. Thank you so much for your participation. We are now going to the end of this event. I would like to invite Professor Vera to be present here and tell us our final messages. I'm very happy. I want to start by saying that I'm truly happy with this event. I want to thank the entire team, all the people involved, all our partners. We know how hard it was, but we are here. And before moving to what we have organized for the end, I would like to say a few words that I wrote myself shortly ago. I need to read. I drafted them on a paper, but it portrays a little bit of my knowledge and how thankful I am to all. So please allow me to read this. And I also want to thank the people that sent us messages, that asked questions, that answered our cloud of words. Our cloud will be posted, and the 3 words with almost health, integration, knowledge are the top 3 words. Thank you so much. So, dear colleagues, allow me to read these few words that come out of my heart. Especially today, in this moment of integration, I dare to share my greatest emotion. This symposium fills my heart. Oh, pandemic due to COVID took away plans and dreams and made us drown in sad and boring experiences. Oh, COVID, what are you looking for? We are here, facing you, and bet we are gonna win. And yet, here we are shining. Brazil, Portugal, Scotland, and Canada. We are happy to share experiences, knowledge, commitments, and ways to make things international. Scientific knowledge, promotion of health and nursing, aim to get bigger and bigger. Partnership, integration, innovation. We have a lot to do. Imagine First Nightingale. Now, holding hands, we will get far. And even at a distance, technology and human knowledge are going to help us. This event, organized by a group that strived hard for everything to happen, welcome you all with a lot of love and gratitude, health and integration. Caring, nationalizing, internationalizing, and why not say philosophy and researching. Thank you for trusting us, and please receive flowers to bring some perfume to your lives. Thank you so much. Thank you. Thank you, Professor Vera. A round of applause to all of you. And now we are going to show a closing video. I think it repeated what I say. And now let's wait for the video with all the people involved. Oh, the cloud. First, we have the cloud. Okay, I'm thrilled here. So the cloud, please. Health, integration, knowledge. Much more than that, science, partnership, inclusion, care, reflection, integration, nursing, international, productive, importance, vulnerability, relevance, experience, reflexive, rich, brilliant, current. So here are all the words that were sent from the participants. Congratulations to you all that took part of this amazing Congress. Let's have the video now.
Levantai, anjos de novo.
to speak about the second symposium, and it's speaking about exchanging experiences, new knowledge, innovation, new learnings. And I hope in this context that we grow more and more and always believe we are capable of reaching new goals, new paths, new ways. The word that sums up the second International Symposium of Graduation in Nursing from the Federal University of Ceará is excellence. Excellence is a brand that we have in our program. It's in what we do, in what we know, with all our professors. And I believe that during these 3 days, we were able to taste that in the symposium. These were 3 rich days, full of knowledge, full of the discussion, of exchange of experiences, cultural experiences, where every country showed us a little bit of what they have, and also what each university is producing. And this enriches us a lot besides the partnership. This partnership with the Federal University of Ceará has with the 3 universities that during these 3 days presented their works with us. I want to say, and I want to congratulate the coordinators of the event. I want to say I know it's not easy to make such a huge event. The second symposium of the graduation program in nursing of the Federal University of Ceará represents a lot of daringness, partnerships, knowledge, and innovation. I'd like to thank the graduation program of UFC, the organizers of the event, and all speakers for sharing their experiences that led us to reflect, and we are sure to transform nursing to promote the health of the population. Thank you. Good evening. A word that defines the second symposium to me in the program is sharing.
Para mim define o segundo simpósio internacional do programa de pós-graduação em enfermagem da UFC.
The word that defines the second symposium to me is learning. I love being a part of the program as a postdoctorate student. This event gives us learning, innovation. Thank you for this amazing moment. This symposium represents innovation, interdisciplinarity, and partnership. To me, the second international symposium of the UFC means gratitude, learning, an opportunity to learn, to understand the roles of research, partnership, solidarity. This international symposium recognizes the importance of partnerships between institutions and countries to develop knowledge and overall for the learning of people and institutions. Considering the different challenges and opportunities that nursing faces regarding this wonderful event together, I want to greet you all, congratulate you all for this event. Professional, personal growth. This event was synonymous with a lot of integration. Good afternoon. We are in the end of this international symposium. And we were asked to say something that defines the way I saw the symposium. And I couldn't have another sentence. Only together we can build nursing with respect for sciences, for human dignity, and oriented to people's needs. And I hope to see you soon. Thank you. Wish you all the best.
Até dia destes e que seja em breve. Muito obrigado.
Sharing experiences. This is what the program represents for the POP program. Thank you so much. Hello, in the end of this event, I would like to highlight those that worked so hard for it to happen. I feel gratitude and say that the graduation program in nursing of the Federal University of Ceará is glad with all the people that were here watching us in such an important event with such important themes. My final words are gratitude, love, integration, internationalization. Together we can do more. We are more. Bye bye. Kiss, kiss.
Juntos somos mais. Abraço a todos.
Well, that's it. Thank you all so much for being here for the second symposium. The guests, thank you. Participants, a big hug to all of you. Thank you for this wonderful moment. Bye. Thank you. See you next time. Thank you all of those that contributed to this moment, the technical team, the organizers, all of you. Thank you.